Hello, I'm Dr. Stephanie Yakub. I am a specialist in obstetrics and gynecology practicing in Dubai, and I am a fellow in infertility at First IVF and Foki IVF here in Dubai.
Hi, Stephanie. I'm Dr. Manjit Ramasamy, consultant urologist at Foki IVF and First IVF in Dubai. So happy to have you.
I'm so happy this is finally happening. So I think we should just get straight into it. I really want to discuss this table of yours. You posted on your social media and it's gotten so much attention. You've really summarized male infertility in a really good and clear way.
So one of the reasons that I tried to make it very simple was because I've realized that most male infertility is actually treated by gynecologists.
Okay.
There are not enough urologists who are either interested in male fertility or urologists who are trained enough to actually treat male patients. I think most gynecologists and fertility specialists such as yourself have a very good understanding of the hypothalamic pituitary gonadal axis, which we are going to be primarily focusing on today, to be able to treat men. And I wanted to make sure that there is a good summary, and I'm happy we are doing this podcast to try and explain that summary.
Yes.
So men can actually be treated properly, both with the correct medication, with the correct dosage, and also to be followed up adequately.
I mean, you can't be everywhere, so at least teaching as many people as we can to manage things in this way will be great. So, like you mentioned, we've got this axis, and medications that are mentioned in that table work in different places. So maybe we'll focus more on the medication aspect and then discuss where they affect. So let's start with Clomiphene citrate.
Sure. So Clomiphene citrate is probably the most commonly used medication, both in female fertility as well as in male infertility.
Yes.
It's been around for about 75 years, and it is basically used to improve egg count, and in men it is used to try and improve sperm count. Clomiphene citrate, as you know, is an estrogen receptor modulator. It basically blocks the estrogen receptors in the hypothalamus and the pituitary gland, thereby increasing both FSH and LH, in turn to increase both sperm count and testosterone. I think Clomiphene citrate will be a very good idea in men who have low sperm count as well as low testosterone, but their FSH and LH are within the normal range.
Yeah.
So anytime we want to increase both FSH and LH to try and see if we can improve both sperm count and testosterone production from the testis, I think Clomiphene citrate will be a very good idea.
All right, fantastic. I think that's a pretty good and clear explanation of that. So let's move on to the next one, Letrozole.
So letrozole and anastrozole
Yes.
are basically estrogen blockers. So testosterone, both in men and in women, gets converted to estradiol, and the enzyme aromatase gets blocked by drugs such as anastrozole and letrozole. So in obese men with decreased sperm count, there is a very high probability that majority of their testosterone gets converted to estradiol. Mm-hmm. And so in an obese male with oligospermia, checking in estradiol and seeing if the testosterone to estradiol ratio is less than 10 to 1. So if the testosterone is 300 nanogram per deciliter and the estrogen is 30, that is optimal. But anytime the ratio is less than 10 to 1, to use drugs such as letrozole or anastrozole to try and optimize the testosterone estradiol ratio would be a good idea. Mm-hmm. And in an attempt to increase testosterone production from the testis, you can also improve sperm production at the same time by using drugs such as letrozole and anastrozole.
Perfect. So in that way, you're blocking the estrogen production. Brain gets tricked and tries
Correct.
to increase the release of those hormones. And that's pretty straightforward. And we'll talk about estrogen a little bit more when we're talking about lifestyle modifications and things like that. But let's talk about the next medication. So HCG.
Sure. So HCG is basically LH. Mm-hmm. It's very similar to LH, and it mimics LH in its action, except that it is very long-acting, which is good because LH gets released in the body every 1 hour, and we can't keep giving a medication every 1 hour. So we give HCG, which is pretty much long-acting LH. HCG is given in men who have a very high FSH and who have normal LH levels and a low testosterone level, where you want to try and increase both the LH and the testosterone level without increasing the FSH even more. because high FSH is not necessarily good because once the FSH levels get too high, that can happen when you give clomiphene citrate, they become biologically inactive. And so I think in this subpopulation of men that have normal LH levels, low testosterone levels, but FSH is high, you can give HCG to try and just influence both the LH and the testosterone axis almost without impacting the FSH. Or in fact, the FSH levels may go down a little bit when you give HCG, but in a way it is good because you're now almost taking the biologically inactive FSH and producing endogenous active FSH.
Exactly. And for those that we need to give FSH to,
Correct.
we've also got that as an option on your table.
Yes, exactly. So FSH should be given in men who have normal FSH levels, but a low sperm count, but at the same time have normal LH and normal testosterone. People always ask me, the first row on the table is very confusing because you have normal FSH, you have normal LH, you have normal testosterone, you have normal estradiol, and it ends with giving FSH. Particularly recombinant FSH. And the concept is very similar, wherein if you have a low sperm count, your pituitary gland needs to pick up the work and produce more FSH.
Yep.
And when it is not making more FSH, you want to supplement with recombinant FSH. And I think that's where the difference is in trying to see if we can improve FSH to try and boost sperm production even more.
Perfect. And so, you know, giving these medications obviously does help and lead to changes. Time frame. Usually patients will ask us, you know, how long do I need to be on these medications? How is it going to affect myself and my partner's timeline with planning? You give these medications for how long before you
move
test
on
again?
And discuss the next steps? Absolutely.
Yeah.
So spermatogenesis cycle takes about 72 days in men. And so usually I give medications for about 3 months. And we repeat the blood tests and the sperm analysis in about 3 months, and then make a decision from that point. Either we continue the medication if I see some sort of improvement. If I see absolutely no improvement, then I check to make sure the hormone levels are not all over the place and they are responding the way it should. And then adjust the medications or stop the medication sometime if it doesn't work. But sometimes I have seen men being treated with urinary FSH sources like Menopur and Mirinal. And I think urinary FSH is obtained from postmenopausal females. And these are likely biologically inactive components of the ligand FSH. And they likely will not improve sperm count because even though they bind to the receptors in the same way that endogenous FSH does, they don't promote spermatogenesis as well. And so trying to give recombinant FSH, which has the proper glycosylation and mimics more of the premenopausal FSH, I think is a much better idea and a strategy, especially in men who have low sperm counts, to use that instead of using urinary sources of FSH like Menopur and Mirinal.
That's fantastic. And it's really interesting to know that there is a difference in thinking that a post-menopausal urinary medication might not be working the same way as the recombinant
Correct.
one. Now, you've said a lot of the medications are the same medications we give women. We're kind of limited, right, with the options that we play with. But there's one medication that's not advised for women to take that has some pretty amazing results, especially in the maturation phase. So tell us a bit about Isotretinoin and the benefits of that in male fertility.
Absolutely. So Isotretinoin has sort of been a complete medication that works by chance. It's a medication that's used to treat acne, and it's prohibited in women who are trying to get pregnant because of its impact on teratogenicity and the potential for fetal malformations. However, in men who have azoospermia, due to underlying maturation arrest, Isotretinoin has been successfully used in about 20 to 30% of men to get sperm back in the ejaculate. And this happens because Isotretinoin has a few functions which it enables to do so. Number one, it's actually clinically safe. It doesn't cause too many side effects other than lip chafing when used at doses of 10 to 20 milligrams once a day.
Yeah.
It doesn't impact its liver, doesn't cause hepatotoxicity. Number two, it can actually penetrate the blood-testis barrier. There are very few drugs that can do that. Isotretinoin just happens to be one of them, where it can enter the testis and actually promote spermatogenesis. And number three, Isotretinoin levels inside the testis, retinoic acid, is important to convert mitosis to meiosis. So spermatogenesis starts off with mitosis, goes through meiosis 1, meiosis 2, and makes sperm. And in that initial phase of taking the germ cells and making it go through spermatogenesis, isotretinoin plays a very important role. So patients with maturation arrest histology, where spermatogenesis is there but doesn't progress along all the way, isotretinoin seems to be a true wonder drug in trying to push spermatogenesis along.
Fantastic. And I know you have had a case of a spontaneous conception and pregnancy after treatment with isotretinoin, but where do you think this is going to fit in the treatment of a couple that are hopefully going to be going for an IVF cycle?
Absolutely. So we were very surprised when we had done a microdissection testicular sperm extraction, and the guy had no sperm after both embryology as well as AI verification. And histology came back as late maturation arrest. And so there were germ cells, but it doesn't progress along all the way to sperm. And I started him on isotretinoin, and the guy came back pregnant at 5 months. And I initially said, this cannot be your child. And we went back and checked his sperm count, and it was about 1 million moving sperm.
It was
which
his.
we were very surprised.
Yeah.
And we just recently published the case report, and and they are pregnant at up to 8 months now. And we showed that in men taking isotretinoin who are able to conceive, the semen levels of isotretinoin are very low, and it appears to be very safe for men who are attempting conception. In women, it is not allowed, but in men, because the levels are low, they can still continue to take it. But more research needs to be done on where isotretinoin will fit, not just in the post-surgical setting, but maybe if we can predict maturation arrest histology based on biomarkers, testicular volume, and so on in the pre-surgery setting in men with azoospermia. I think this will revolutionize the way we look at spermatogenesis and azoospermia with using a simple medication like isotretinoin.
Fantastic. And one last thing that we really talk about is, apart, from other medications, the GLP-1s, so Ozempic and things like that. So we know general lifestyle modifications, weight loss, but specifically when it comes to sperm, what advice do you have on the benefits that these medications will have on the outcomes and the parameters? Absolutely.
So obesity and metabolic syndrome has become a very common condition. It's an epidemic. It's become a pandemic. Inclusion of fast food, sedentary lifestyle, and so on. I think obesity, 30% of US adults have been deemed to be obesity. WHO is reclassifying BMI levels to classify obesity because we are putting too many patients into the obesity diagnosis. GLP-1 agonists have revolutionized treatment for obesity. Ozempic and Mounjaro have become dinner table conversations. And nice thing in our field of male reproduction is that one of the studies where men were able to lose weight by about 25%. So if they were 125 kilos and they were able to come down to 100 kilos in about 6 months, the sperm count improved by 50%. So we finally have the first evidence that weight loss, either with or without GLP-1 agonists, is able to improve sperm counts. Because testes are supposed to be cooler. They're 34 degrees centigrade intertesticular temperature, body temperature is 37 degrees centigrade. In obese men, there's a lot of heat around the testis, which basically both impairs sperm production and testosterone production. And I think weight loss will basically try and decrease intertesticular temperature, in addition to affecting metabolic parameters like testosterone production and sex hormone binding globulin and so on, that I think will help in sperm production.
And just a quick question there, with weight loss, is it the same as in women where big sudden losses of weight can actually lead to hyper things and issues and concerns when we're talking about the axis? So is it the same with men where bariatric surgery might lead to too quick of a weight loss and it actually might affect things in a negative manner?
Absolutely. So I don't think we have enough research to say acute weight loss. When GLP-1 agonists are used, it's likely over a prolonged period of time where weight loss is more gradual. But I agree with you, when bariatric surgery happens and there is a sudden drop of weight, there is a decrease in production of pituitary hormones. I've actually seen patients suffer from sexual dysfunction and ejaculation and additional male reproductive problems in addition to just low sperm count that happens with acute weight loss. We still don't have enough research about what happens to sperm counts because usually it's the elderly population that are undergoing bariatric surgery. But with chronic slow weight loss that happens with GLP-1 agonists, we don't seem to have an adverse effect on sperm production.
Okay. And speaking of shocks to the system, something that you've really been working on and thinking that this, might be something that will really change the scene is resetting the system. Mm-hmm. So I like to really simplify things, as in you unplug and replug it in and let's see if it works. So talk a little bit about that reset, gonadotropin reset protocol.
I love the analogy of unplug and replug, because I think anything that doesn't work anywhere in IT, not an IT guy, you just turn it off and turn it on, seems to work most of the time. And that's usually the fix that anytime you call customer service, that's what they ask you to do. I'm going to use that from the future. But basically, so in men who have primary testicular failure, who don't have enough sperm production and or testosterone production, have chronically elevated levels of both FSH and LH. Yeah. These are hormones that are made by the pituitary gland. When the levels are very high for a very long period of time, two things happen. Number one, their actual ligand, FSH, that is being produced gets glycosylated in such a way that it renders it biologically inactive. Mm-hmm. Same phenomenon that happens in postmenopausal females. When women get older, FSH is no longer needed, reproduction doesn't happen, and so high levels of FSH render themselves biologically inactive. The second interesting thing that happens is receptors in the testis, when they are exposed to chronically high levels of FSH for a long period of time, basically also become inactive. Yeah. They become internalized. They don't function as efficiently as they do. So I think turning off and turning on is a good way where now we can give medications such as a testosterone injection, which is long-acting, or we can give GnRH agonist and or an antagonist, as is done in female IVF cycles, or very high doses of HCG, which will shut down the GnRH production from the hypothalamus. This will basically shut down the endogenous production of FSH for about 6 weeks and basically restart the system with gonadotropins like recombinant FSH and recombinant HCG, such as Ovidrel, mm-hmm. to try and see if we can make new FSH and new LH that can both promote spermatogenesis by a ligand as well as to activate receptors in the testis that can actually help spermatogenesis. So sort of a relatively new concept. We're doing this under a research protocol here at First IVF. We are informing patients of the potential risks of taking testosterone injection and potentially taking GnRH agonist and antagonist. But these patients are desperate. This is their last hope. They want to optimize either everything before their surgical sperm retrieval procedure, or they've already had a surgery and now they want to optimize it for a potential second surgery. So I think we're sort of testing this, but it seems to make a lot of biological sense, and we have to wait for the results to validate this.
Fantastic. And I think that's exactly it. You touched base on, despite the fact that there might be side effects of having, shut off their testosterone for a long time, these are not patients who have just, randomly fertile men. These are people who have reached a point of probably being told by many urologists or andrologists before coming to you and you saying, this is our last resort. Let's try and help you further before proceeding with surgical treatments, or even saying that there's maybe, medical therapy might fail altogether.
Absolutely. I think that's why we've established this gonadotropin reset protocol based on the gonadotropin reset hypothesis, that if we are able to give a testosterone undecanoate injection, which is long-acting, it usually suppresses the FSH and LH production in about 6 weeks, depending on how high the levels are. And then we can restart them with giving recombinant FSH and LH, which mimics more of the premenopausal female FSH and LH, which is biologically active, and at the same time having their own pituitary gland make new FSH and LH, which will likely be biologically active. And I think this makes a lot more sense to try and stimulate spermatogenesis than to try and give medications that would only increase their production of FSH and LH, which is already biologically inactive.
Exactly. Amazing. Well, thank you so much for a really great summary of all of the medical interventions that can be done even before getting to surgical ones to begin with. This was really informative.
Thank you very much.
Thank you.